Bismillahirrahmanirrahim. In the module 2 of the CSIR program, we are going to explore the consultation models. Doctor-patient consultation is the topic that lies at the very heart of medical practice. As future doctors, your ability to communicate effectively with patients will be just as important as your clinical knowledge and skills. It contributes to the attitude and behavioral aspects of the patient encounters. You'll be able to understand the various consultation models and describe the most widely used consultation models and their strengths and how to apply them in real-world clinical settings. Now imagine the situation. A patient comes to you with vague complaints of feeling unwell. She hesitates to share her details for reasons unknown to you, but you have a limited time to figure out what's happening and what's wrong with her. Despite her hesitation, how would you structure this conversation to ensure that you don't miss anything important? It doesn't seem easy, right? This is where consultation models come in. Why is it important to use a consultation model? Think about it. Every diagnosis, treatment plan, health outcome begins with a conversation. The way you structure that conversation can make all the difference in understanding your patient's needs, building trust, and providing high quality care. Consultation models are structured frameworks that guide doctor patient interactions, providing a roadmap for navigating the clinical encounters systematically and effectively, and ensure that all the aspects of the patient histories, concern, expectations are addressed logically in a patient centered manner. But we must remember that these are not rigid scripts which should be followed as such, but rather they are flexible tools that can be adapted to different patients and different clinical contexts. These have three important characteristics which help us to have a good doctor patient communication and deliver a holistic, comprehensive care by addressing patients' issues. And these three aspects are efficiency, comprehensiveness, and patient centeredness. Typically, physicians have 10 minutes during a consultation. So, these frameworks help us to efficiently utilize our time with each patient. And it ensures that we collect a comprehensive information without overlooking any critical information. And we remain patient centered by building rapport, explore and addressing patients' ideas, concerns, and expectations, and involving them in shared decision making. Let me ask you a question. After how long does a doctor interrupt a patient in a consultation? Let's find out through research. A research was done in which the several doctor-patient consultations were recorded, and it was seen that after how long did the doctor interrupt the patient. According to Marvel, 69% of patients were interrupted within 18 seconds of describing their presenting complaints. In another study, they found out that average time before interruption was 11 seconds. So generally it is observed that the physician interrupts the patient within 10 to 15 seconds of the consultation. So, what does this lead to? Missed or incomplete information because the patient has not been given a chance to talk. The patient dissatisfaction and disengagement because the patients feel unheard and reduced trust in doctor patient relationships. What we must remember is that patients are human beings with emotions and expectations. But for us, the main challenge is to allow the patient to tell their stories or their problems in their own language and words, and then make sense of the patient's story in medical terms. Therefore, historically, consultation models have been evolving. The traditional biomedical model, which is still being used, was developed sometimes in 1850s, and this model, it views health and illness strictly through the lens of biological factors, excluding all psychological, emotional, and social influences. The doctor focuses on the cross-sectioning to get the medical information about the disease. And the doctors are seen in a superior position as experts who diagnose and make decisions to treat the patients with medication or surgery. Patients are generally seen as passive recipients of care, expected to follow doctors' instructions without giving any input of their own. So there was a need to move from a doctor centered model to a task oriented model and then a behavior oriented model, and finally, the latest models are patient centered. This is a long list of how the various models in various years have been evolved, and how this list is the ongoing list. Even till today, many more new models have been added according to the needs of the patients. But while the biomedical model was incredibly successful in treating many diseases and advances in medical sciences, it has been criticized for being too narrow and overlooking the psychological, social, and emotional aspects of health. However, it is still used in acute care setting and emergency rooms where getting the biomedical information is the first thing we have to do. So each model still has some value, and then the models move towards a more with focus on more emotional aspects or the psychosocial aspects of the patient's lives. And therefore, the Bellent model looks at the doctor, his patient, and illness, and introduce the concept of doctor-patient relationship and emphasize the emotional aspects and understanding the patient's perspective. Whereas the transactional analysis focused on interaction of doctor and patient, highlighting that each has a specific role, like of a parent or adult or child during communication. All said and done, there is the differences between the older traditional biomedical models and the newer or the modern patient-centered models are that the patient has a more active role rather than a passive role. Patient is a partner in treatment plan rather than a recipient of treatment. Physicians collaborate with the patients rather than dominating the conversation. Care is Care is quality of life centered rather than disease centered. And physicians listen more and talk less rather than doing most of the talking themselves. Therefore, patients are more likely to adhere to treatment plans because they are involved in the shared decision making. Calgary Cambridge model came out in 1996, and this is the most frequently used model for teaching and assessing communication skills in medical consultations and teaching medical students how to ha- conduct the doctor-patient consultations. So this is a structured guide that focuses on communication skills and building rapport, and it provides clear communication framework which promotes patient engagement. But the the other side is that it can be very rigid if it is overstructured. So this model needs to be customized according to the patient's needs. It has 5 steps. We initiate the session with the preparation, looking at the notes of the patients, and then immediately we try to make an initial rapport with the patient and find out the reasons for consultation or the presenting complaints. Then we move on to gathering information and exploring the patient's problem. So first the biomedical information and then the patient's perspective. And we also don't ignore the patient's background. Where does the patient come from? What sort of a social setup? What is the context? And then we move on to the physical examination to make the differential diagnosis. And finally, there is the phase of planning and explanation and planning, where we provide the patient information, the type and amount that the patient is able to understand. And then we ask the patient to repeat to ensure that the patient has understood what we have said, and move on to a shared decision making with the help of the patient to choose the treatment which the patient will be able to carry out. Finally, there is a proper closing with points of closure and forward planning about the follow-up, etc. So it provides a proper structure on one hand, and on the other hand, it also helps us build up a relationship or a rapport with the patient. So this is the model which is usually used to teach medical student communication skills for doctor-patient encounters. The models kept on moving from patient centered to shared decision making and motivational interviews, and they are still moving. But the two aspects which are which are the backbone of the modern approach, are the patient-centered care and the shared decision making. There were several strategies which were used to help medical students and physicians remember the points of the consultation. And one such example given here is the neighbor in a consultation model, in which we use the fingers to remember the steps of the consultation. For example, we begin with the index finger, which is connecting and forming a rapport with the patient, and then the middle finger, where we summarize and ask the patient to summarize and repeat to ensure that the patient understood what we are saying. And the ring finger is handing over, that is making sure that the patient agrees to our treatment plan. And the little finger is safety netting, which is that we anticipate that what are the unexpected problems or the barriers which the patient might face while following the treatment. So we need to have a contingency plan for that. And then there is housekeeping, in which the doctors need to take a break and before calling in the next patient and prepare themselves for the next patient. Another commonly used model nowadays is four habit model, developed in 1999, and it has also a proper there's beginning and then eliciting the patient's perspective, and it also helps us demonstrate empathy by being more open to patient's emotions and make at least one empathetic statement and convey empathy non-verbally and be aware of our own reactions as well. And then investing in a proper ending with delivering the diagnostic information, providing some education, involving the patient in decision making, and completing the visit, etc. Where do we stand? We are following the traditional consultation model, which consists of history taking, physical examination, differential diagnosis, and disease management. But does this cover patients' needs? Is this a patient centered approach? What is the way forward? The way forward is that we integrate the disease framework and the illness framework, or the biomedical model which we are following, with the patient centered model. So the doctor has to actually move to and fro between the two models while in the consultation, patient consultation. We begin with the patients, where the patient presents the cues of unwellness or presenting complaint, and then the doctor explores the biomedical information and moves on to also explore the ideas, concern, and expectations of and feelings of patient, and see how it affects the function or the disease of the patient. And then the doctor moves on to do a physical examination, etc., for a differential diagnosis. At the same time, moves to understand the patient's unique experience of illness and how the patient is going to follow your treatment, and you give a differential diagnosis. So there's an integrated understanding between the biomedical aspects and the patient's perspective going on to and fro during the consultation. So this is what is required, and this is which you do in our consultations. So that was all about the consultation models. We'll be using these in our role play, simulated patient encounters, as well as real patient encounters during the course. But before that, I want you to have a look at the ineffective interaction with the patient video on the Moodle, and also the effective interactions. And then we'll discuss these videos and ask you to do some reflective writing on the videos as assignment during the in-person sessions. So thank you for today, and you're listening. If you have any questions, you're most welcome to post them on the Moodle discussion forum or ask them in person to me. Thank you.